Alveolar proteinosis. Causes and pathophysiology. Decreased surfactant clearance. Autoimmune PAP. 90% of cases. Autoimmune PAP is initiated by immunoglobulin, Ig, G antigranulocyte macrophage colony stimulating factor, anti-GM-CSF, antibodies. Secondary PAP. 4% of cases. Decreased functional macrophages. 1. Re-immunodeficiency or secondary to hematological malignancies. Congenital PAP. 1% of cases. Genetic mutations in GM-CSF receptor proteins or surfactant proteins. Decreased surfactant clearance. Epidemiology. PAP is a rare lung disease. Prevalence has been reported to be from 3.7 to 40 cases per million depending on the country. The incidence has been estimated to be 0.2 cases per million. In autoimmune PAP, males are more commonly affected than females at a 2:1 ratio. The median age at time of diagnosis is reported from 39 years to 51 years, although ages range from newborn to 72 years old. Key player. Surfactant. It is a key component within alveoli that prevents end expiratory collapse by decreasing alveolar surface tension at the air-liquid interface. Surfactant is also crucial for host defense at the alveolar level by opsonizing microbes and signaling innate defense mechanisms. It is synthesized and secreted by alveolar type II epithelial cells. Both type II epithelial cells and alveolar macrophages are involved in the breakdown and clearance of surfactant. GM-CSF, granulocyte macrophage colony stimulating factor. GM-CSF is a crucial cytokine involved in host defense against pulmonary bacterial, viral, and fungal infections and clearance of surfactant. Clinical presentation. History. Dyspnea is the most common presenting complaint, present in 39% of patients in one report. A cough was reported in 21% of patients. Fever may be present in 24% of secondary PAP patients due to concomitant hematological malignancies or opportunistic infections. 33% of patients may be asymptomatic at the time of presentation. A majority of patients are smokers, 53% to 85%. Many report occupational exposures, 39% to 48%. Physical examination is frequently normal. Patients can present with cyanosis, 25% to 30%. Clubbing, 30%. Or inspiratory crackles, 50%. Investigation. Chest radiography may demonstrate bilateral alveolar opacities in a perihilar and basilar distribution without air bronchograms. This is sometimes referred to as a batwing distribution, or may resemble pulmonary edema without cardiomegaly or pleural effusions. Computed tomography reveals intralobular thickening and diffuse ground glass opacities. This pattern is often referred to as crazy paving. Crazy paving is highly suggestive of PAP although not specific or sensitive enough to confirm the diagnosis. Lower lobe predominance has been reported in 22% of cases. Investigations. Lung biopsy. Open lung biopsy or video-assisted thoracic surgery is rarely done but will demonstrate PA-positive lipoproteinaceous material. Testing for IgG anti-GM-CSF antibodies is the only clinically relevant biomarker to date. An anti-GM-CSF antibody level of 2.8 micrograms/ml or greater is abnormal and is consistent with PAP. Pulmonary function testing. The most common pattern on spirometry is a restrictive pattern. Spirometry may be normal in 30% of patients with PAP and may have a mixed obstruction and restrictive pattern in those who are smokers. A significant reduction in diffusion capacity. Bronchoscopy. When PAP is suspected, bronchoscopy with bronchoalveolar lavage is the gold standard for diagnosis. The lavage return will often appear milky and opaque. BALF cytological examination will reveal large foamy macrophages with amorphous material that stains and give positive periodic acid Schiff staining. Treatment. Whole lung lavage. The current standard of care for autoimmune PAP is whole lung lavage, WLL. The decision to treat is based upon signs of poor gas exchange and symptoms of respiratory distress. Patients with mild dyspnea or no symptoms can do well with supportive care and monitoring of pulmonary function tests and chest imaging. Whole lung lavage should be considered in patients with dyspnea at rest, resting PAO2 less than 65 mm Hg, resting alveolar arterial gradient greater than 40 mm Hg or oxygen desaturations on 6-minute walk test. Whole lung lavage. Done under general anesthesia with double lumen tube, each lung with a time lapse of 48 HRS or more. 15 and up to 40 liters of warm saline is used with 1 liter cycle and suctioning. Lung percussion and positional decubitus change during the procedure has been reported in many centers. The average duration of benefits following WLL is 15 months. A review found that 70% of patients underwent WLL within 5 years of diagnosis and that on average patients required 2 whole lung lavages. GM-CSF replacement therapy. GM-CSF showed a positive response in 48% of a small cohort of 25 patients. Improvement following GM-CSF injections was much slower than the standard WLL, and therefore, this therapy has fallen out of favor. Immunomodulation. Systemic corticosteroids were trialed in autoimmune PAP but were ineffective, and they were found to increase the risk of pulmonary infections. Rituximab, an anti-CD20 therapy, was studied in 8 of these patients had significant clinical improvement despite no change in serum anti-GM-CSF levels. Both rituximab and plasmapheresis are considered alternative therapies for PAP refractory to WLL. Prognosis. Disease course varies, and the prognosis is unpredictable. When treated with whole lung lavage, the 5-year survival of autoimmune PAP is 95%. More recent and more extensive analyses have concluded that spontaneous remission occurs in less than 10% of patients. In a retrospective analysis of mortality in PAP patients, 72% of deaths occurred as a direct result of respiratory failure while 20% were due to secondary infections. The prognosis for secondary PAP is worse with a median time for survival less than 15 months. The causes of death in secondary PAP patients include the underlying hematological disease, 33%, infection, 25%, respiratory failure, 25%, and bleeding complications, 13%. Thank you.